privilege to be here. What I thought I'd review, and I've clarified some of the medical jargon in the talk so that hopefully everybody will understand what I'm talking about. But there's an awful lot of literally hope and hype in the whole arena of medical and dermatologic and cosmetic rejuvenation. So I thought I'd try and put in perspective some of the honesty of some of the claims of the treatments that are being promoted, because there are some really good treatments and there are some treatments that still have question marks, I believe, over them. And let's go there. There we go. So just as a very, very brief introduction who I am, as Liz said, that all dermatologists in the United Kingdom still have to train as internal medicine specialists before we're allowed to train in dermatology, which is a little bit unusual. Most other countries don't require that, so we do have a much broader basis of training. The other problem with that is, of course, it takes years longer to train. But I did a number of different training positions before moving to the United States. And the reason I went to the United States in the mid-70s was so I could continue to do research. At the time, it was difficult to get research funding in this country. And so that led us to moving to San Diego, where there's the Scripps Clinic and Research Foundation. And then I stayed in California as a professor at UCLA until the early 90s, when one of my daughters decided to come back to study medicine in this country, and then finished up by meeting an English guy who then finished up by having children, and we have now more grandchildren in the UK than we do in the United States. So that's what brings us back here more of the time, although we do still have a base in California. But why, people wonder why dermatologists have become involved in the whole arena of cosmetic rejuvenation. And if you look at some of the really breakthrough treatments that have been developed in this whole area, many of them were developed by dermatologists. Most of them, it's fair to say, are United States dermatologists. But if you look at chemical peels, hair transplantation, the use of lasers in medicine in general, these were all actually pioneered by dermatologists. And so moving really to the more recent developments, the use of the fractionated lasers, the use of botulinum toxins or Botox, these were all developed. Actually, Botox was developed by a Canadian couple who was both a dermatologist and an ophthalmologist. And we did some of the very first research on Botox with them. There were dermatologists that developed the latest developments on lasers. There were dermatologists that actually developed, some of you may have heard about cool sculpting, fat reduction by control freezing of fat. That was again developed by dermatologists. So we do have a lot of innovation in dermatology. And I always like to put this slide up, particularly if I'm lecturing to an audience of plastic surgeons, because they always get a little upset about it. Anyway, so the last 30 years, there has been a true revolution in non-surgical cosmetic treatments. And what I thought I'd discuss, I selected a few important topics, or what I thought were important topics, and that was the improvement and the need for sun protection. Because if you're going to do one thing that you can do for your skin, it is sun protect, and that's probably the most important single thing you can do. Some of the prescription creams, the vitamin A related, retinoid related creams, have had a lot of evidence-based research. The botulinum toxins are now used for over 100 different medical applications. And I think the third application was the reduction of facial lines, and the other was the reduction of severe localized sweating. We could now use some of the newer fillers to both lift and fill the face and other parts of the body. Lasers and lights, as I say, have been developed and are very, very diverse now. And then non-surgical body contouring is one of the major advances. So we've now got, because of the last developments over the last 20 and 30 years, we've got treatments that actually have revolutionized the treatment of problems that we could never treat before. This is one patient with a particularly disfiguring birthmark, where they get these dark, discolored areas on their faces, and it has been revolutionized by laser treatments. We did not have any treatments for these patients until the development of lasers. And some of the newer fillers are really highly effective at reducing some of the disfiguring scars and loss of volume that people can get as a result of aging, but also more as importantly, the result of loss of volume from scarring, from severe acne, from inflammation. So some of these newer techniques are quite revolutionary, and they've all taken place in the not too distant past. So let's move on to some aspects of rejuvenation. Why do our faces change with age? We all will have natural aging, but it's the accelerated aging that some people get concerned about, and there are some, as I will show you, some things that we can do to slow this. There's two types of aging. There's intrinsic aging, which we will all age at a programmed pattern, which is obviously genetically determined, and clearly one of the most important factors here is to choose your parents carefully. But there are newer work that's going on at a molecular level to try and modify the intrinsic aging. Some of you may have heard about the telomere theory of aging, where there's little caps on the ends of our chromosomes in our cells that gradually age or disappear, and as they disappear or reduce, so the cells age. And some of the new treatments, there are some novel treatments that are being looked at there. I would say that they are for the future. But probably the most important reason for accelerated aging are the extrinsic aging problems as regards lifestyle. And that includes sun exposure, smoking, pollution, diet. Those are probably the most important four keys whereby accelerated aging can occur. And obviously not just appearances, but obviously general body accelerated aging is all tied up with these factors and these lifestyle choices. So some of the proven links about diet, lifestyle and the skin and with other tissues as well include poor diet, and certainly diets that are high in what we could describe as bad carbohydrates, high glycemic index carbohydrates will damage DNA and will accelerate aging. Inflammation, not just in the skin, but inflammation as regards arthritis, bowel inflammation, will accelerate aging in those tissues. Obviously, skin aging is accelerated by skin inflammation as well. This includes severe acne, it includes trauma, it includes the inflammation of severe sunburn, all of those. And ultraviolet not only produces skin cancer, but accelerated aging. I can usually tell when somebody walks in my clinic if they're smokers or not. And you can also tell if you've been fortunate enough to be able to persuade them to stop smoking, because it usually takes about 3 months, and you can usually start seeing that improvement in skin quality and texture after they've stopped smoking. Smoking accelerates the skin by damaging the DNA, by damaging the skin with free radical damage, etc., etc. So I'm not going to go into the specifics on that, but all of these lifestyle choices can accelerate aging. Alcohol in some of us can produce a condition called rosacea, which is, it's not the only cause of rosacea, but with the alcohol inducing redness of the face, inducing enlarged blood vessels, etc. And then there's a lot of unproven links, including some of these. I'm a great disbeliever, even though they're advertised on the back of the London buses, of the benefits of collagen drinks. I've yet to see any real proof of that as yet. So how does the face age? Well, one way it ages is that it loses. If you look at babies, the reason that babies have absolutely no wrinkles usually is because they have a lot of subcutaneous fat, and they're plump, they're round, they're happy, and they usually have round and oval faces. And so that's basically the youthful shape of the face, and that will be, the youthful face of the youthful shape of the face is where you have this nice full oval shape. As we age, we get several changes. We develop what are called hyperfunctional lines on our faces due to repetitive muscle action. We lose volume, and as we lose volume from this part of the face, we also develop sagging and dropping with hollows, deeper lines, and sagging. So this is basically mechanically how we age. And again, we age differently with different genetic background. Now, the other important reason about why faces age is repetitive sun damage, and it doesn't have to be intense sunburns. It can be low levels of repetitive sunlight coming through things like car windows. One of the big concerns that people don't realize is that if you drive a lot, you will finish up by getting significant damage to the elastic tissue of the skin, of the face, on the side of the driver's window. And this, for example, was a truck driver in the United States, and he basically has considerably more sun damage on his driver's side, and research has also shown significantly more skin cancers and aging on the driver's side. So UVA is a major factor in skin aging, and you can get UVA on cloudy days, you can get UVA through car windows, through windscreens, etc., etc. So it doesn't have to be a bright sunny day. And so I think this is, again, if you're concerned about maintaining as healthy a skin as possible, just bear that in mind. And bear in mind that there are certain places that a lot of, particularly women, forget to put sunscreen on. And that's the neck and the chest. And this, for example, this photograph shows you can filter the ultraviolet photographs and show up the amount of sun damage. All of these brown areas are actually sunspots about to appear. And so the neck and the chest, the back of the hands, classically, again, exposure chronically to UVA will be areas that can give that can accelerate your aging appearance. So first thing, what have we got as regards topical things, as regards creams, as regards protection? Well, there's really been some very, very good, and we're very fortunate in Europe. Europe has the best sun protection that there is, far better than in the United States, because the Food and Drug Administration in the United States over-regulate sun protection in the States. In Europe, we have far better sunscreen ingredients, particularly against UVA. So again, you've got well-documented protection, you've got the SPF factors, and my suggestion is an SPF probably of 30 each day, and in addition it has a little circle around the UVA, so I think those are the things to look for. And some of the bigger companies don't go off looking at expensive cosmetic ingredients or cosmetic lines. You don't need to do that. If you find a sunscreen that you like the feel of and you're willing to use every day, stick it on every morning. And then with women, they can put their makeup on top. With men, hopefully not many of them do, but if they're willing to do it, they can put it on after their shave and shower. So there's lots new and sunscreens, as I say, they're well labelled and they're well tested with the major brands in Europe. What about prescription topical creams? And there's some really good evidence that some of the prescription creams are able to reverse some aspects of skin aging. There is much less evidence for the non-prescription creams, the cosmetic products that you can pay oodles of money for. There's much less evidence for that, if any. And so creams, honesty, hope, hype, evidence. There's absolutely good proof that sun protection, that prescription retinoids, which were pioneered by a marvelous American dermatologist, Professor Al Kligman, in the 70s, could convincingly be shown to reverse skin aging. Some of the other newer retinoid creams can do the same. Probably proven are some of the lower strength retinol creams and some of the antioxidants and some of the fruit acids, providing you don't have sensitive skin. It's actually appropriate. I've just realized that, of course, in the old days they would be called snake oil salesmen, and I would say that a lot of the modern products, sadly, are snake venom salesmen. Yes?
Are physicians willing to prescribe the Retin-A?
Well, they are in some countries, and some certainly I am more than willing to provide prescribe Retin-A. If you go to your GP, the problem is that these are not covered by the National Health Service. And
it'll still be cheaper than a over-the-counter retinol?
Yes, they can be, absolutely. They can be. It depends where you go for your prescriptions. The pharmacists do vary in what they charge for prescription retinoids. But you can go to some pharmacists that are very reasonable and are considerably less expensive than over-the-counter products. Yeah. By the way, just either make a note and I'll take questions at the end, or interrupt. I think that's great.
Is there anyone that you recommend, the prescription one?
Well, I always prescribe either tretinoin, which is the version of Retin-A, or something called tazarotene cream, which I'll show you about in a moment. Yeah, and I don't have any shares in either company.
Prescription bad?
What?
Your prescription bad with you?
Yeah. So this is one of the studies that we did some years ago, where there's a product called tazarotene, which is one of the latest generation of retinoid creams. And if you look, this was a comparison between tazarotene and Retin-A cream. This happens to be Retin-A. And if you look at both groups of patients which are randomized, both groups of patients actually produced a very significant improvement in the rejuvenation scores. And there was very little statistical difference. There was a little bit at one point. But both these prescription strengths of Retin-A produced well over 50% improvement at about 6 months. And this was the sort of improvement that one can expect to see. You've got this patient here with moderate sun damage, with sunspots, with wrinkles, with poor quality skin, as early as 8 weeks. And you get similar appearances with Retin-A. You can see significant improvement, and at 6 months into treatment, again, you can see very significant further improvement. And there's no reason why these cannot go on being used. They're perfectly safe to be used. One of the big problems occasionally that we see is irritancy and redness and scaling. But if you reduce the frequency, if you use moisturization, etc., these are very, very well, these are tolerated over many years of treatment. So I think there's very good evidence with Retin-A, with prescription creams, with probably some of the retinols, but I think some of the other ones do have a large question mark. And I think one of the most important factors with any non-prescription product is sun protection. Because if you use that every day, the Australian studies recently have shown quite clearly that you not only reduce the incidence of skin cancer with daily sun protection, you also improve and reduce accelerated aging. So I think there's quite definite evidence for sun protection and prescription products. What about some of the other treatments that we're now using? As I say, we did some of the very original research way back in the 90s on botulinum toxin, as it became known as Botox. And this was where the numbers of patients that were treated way back, and then basically in 2097, this was here, 2001, sorry that doesn't show up, but that's 2001, this is 2010, and this is 2015, and these are millions of procedures. So anybody who was fortunate enough to have stock in Allergan probably did quite well, and it did actually produce the single most important factor in the whole development of non-surgical rejuvenation has been the development of botulinum toxin. Soft tissue fillers have also played a significant role, but chemical peels, which have been used for many years, have not really increased to nearly the same degree as the botulinum toxins. So I think there's no doubt that botulinum toxins have revolutionized this whole area. Now, if the British had been a little bit more savvy as regards our marketing, we would not be going around talking about being Botoxed. We would go around talking about being disported. And the reason is that there were two main botulinum toxins developed, and they were both developed in the Second World War. And they were developed because the military wanted to develop a vaccine for the troops to be protected in case the enemy started lobbing over bombs containing biologic warfare agents, including botulinum toxin. So Salisbury Plain, Porton Down in the UK, had developed very successfully what became known as Dysport, which was the botulinum toxin A from this country, and somewhat after that the Americans developed Botox, or what became Botox, their warfare agent in Maryland. So the two were actually developed very similar timing, but after the war, and I'll show you why it was developed, but what became known as Botox was actually developed as a controlled reduction of muscle spasticity, which was then developed for stroke patients, cerebral palsy, squinting and strabismus, where you get spasm of muscles. So that was the original uses of Botox, and it was developed by a very innovative American ophthalmologist by the name of Scott. At the same time, in this country, Dysport was being used for also spasticity and squint. So as I say, the Americans just were better marketeers and developed Botox, and there we are today. But I've been involved in developing and refining Botox for over 30 years, and we published some of the first controlled research studies on it. And my goal certainly now is to, I don't like the frozen face, I like a natural appearance, and I think that you want to retain a little bit of movement, but you can actually significantly reduce. This patient is here 10 days after injection of one of the botulinum toxins. And you can see a very significant, we've not cleared all the lines, but we have reduced the lines, and importantly, we have also not only produced less lines, we've also produced a natural brow lift. So the natural look is very practical, and quite, if it's used correctly, and that's the key, is that it can be very successful. So what we observed in some of those early studies, sorry, yeah.
How long does the effect of it last? And do you have to keep repeating the treatment?
You do, but some patients it will last 6 months. The question is, how long does Botox last for, or Dysport last for? It will last approximately, on average, 5 months, 6 months, 4 months. It depends on the strength of the muscles, and it's in some patients after you've, if you will, retrain the muscles, sometimes it will last 10 or 11 months. So that's the sort of range. Does it, one question is, if you stopped using it, does everything collapse and fall back? Well, it actually doesn't. It just goes back to how you would have been. It doesn't over correct itself. And this is another, what we observed in the original studies that we published was that we not only produced a reduction of the frown lines, this is the same patient but just overlapped 10 days, 2 weeks later, but you can also see significant brow lifting here compared to here. So again, it's a key of playing with the what's called the depressor muscles of the brow and the elevator muscles of the brow, and the same can be also used for the eye muscles, which led to all sorts of cartoons. She looked so awake, so alive. Was it caffeine or was it Botox? And I guess if you're a coffee addict, it could be both.
Yeah.
But it is actually much more complex than one thinks, and it is interesting that if you look as a physician at some of the training courses, they can transform you into a Botox expert in a lunchtime's training session, and off you go. You can then claim all sorts of wonderful areas of expertise. It's actually much more complex than people will realize, and you've got to really know where the muscle actions are. You've got to know exactly where to place the Botox. You've got to know exactly the dose and the dilution, etc. These are, it is a potent prescription, injectable medicine, and I shall probably leave it at that before I... But other areas that can be successfully treated are the neck and the lower face. And a colleague of mine in Switzerland coined the phrase the Nefertiti lift, after the Egyptian queen that apparently had a superb neck and jaw profile, but he injected the lower facial areas. This is just a mark to show where I injected this particular patient, to define the jawline and reduce the downward pull of the neck and lower facial muscles. So botulinum toxins are very diverse and are very powerful in their effects, and can be very well used. It's, as you say, the lower facial muscles can project all sorts of emotions. I won't hazard a guess at what Bill Clinton was worried about, but it probably was something to do with Hillary or something. But again, this muscle here, which is actually one of the chin muscles, mentalis, can produce all sorts of expressions which some find worrying, I guess. And so again, we can readdress this. Sorry, that doesn't project very well. But these are all different areas. So the last 28 years, what have I learned about Botox? I've learned that definitely less is generally better, that each patient needs their individual doses. You can't have a standard procedure. They all need individual injection sites. The patients, we always listen to the patients and show them they get to show us in the mirror the sort of results they want. We can send all patients, and I actually helped develop the General Medical Council guidelines on this. And basically the bottom line is that it's interesting but sad, and probably not saying that only physicians and surgeons need to follow General Medical Council guidelines. The other practitioners can follow whatever they want. So, anything on questions on Botox? Yes.
So I know some people, I can't remember the actress that had an allergic reaction to collagen in her lip.
Yeah.
But what cases with allergies to Botox, and because it's a 6-month period, or that it's not that serious because it's a short period. I mean, I know also fillers, people have had allergies, but what in the worst scenario sort of allergic reaction could you have to Botox, or does it not really happen like collagen reactions?
Yeah, no, that's a really important question. We've treated many thousands of patients with Botox and Dysport. We've probably seen about 1 in every 10. I may have seen about 2 patients with a true allergy to Botox or Dysport. So it's fortunately, for whatever reason, it's incredibly rare. The side effects that are possible with Botox is overcorrection, or injecting in the wrong place and the wrong site with the wrong dose, where you can get dropping of the brows, where you can get dropping of the lower face, you can get asymmetry, so the patients can get unattractive drooling of the lower face, which isn't what they actually wanted. So all of these are quite possible. So, and that can last. So there is no antidote to Botox.
That's what I'm doing.
There isn't. No. You have to wait until it's the nerve muscle connection has reconnected, and it recovers after about 4 to 6 months. So that's the key. You do need. It does recover. It does recover. There was a group of patients that did get a pirated Botox in Florida, and they finished up by having managed to, in fact, several of them finished up on artificial respirators because they managed to paralyze themselves so much but that was, it was probably 1,000 times the dose that they should have used.
So I picked up what you were saying.
Yeah,
it's people that learn it
in a lunchtime training session. It's not really ideal, put it that way. Okay.
For the allergy?
Is what?
Is there a test for the allergy?
Yeah.
It hardly ever occurs. There are tests, and what we do is if we have a patient who has a potential history of allergy testing, we do the tiniest dilution subdermally into the skin as a skin prick test, and we wait several days and observe them. But again, that needs to be done under medical supervision. Yeah.
Can I just ask them,
Yeah.
what are you referring to as an allergy to Botox?
What we're referring to as an allergy to Botox is somebody that gets itching and burning and hives and stinging. Yes. But it's very, very, very rare. We've seen, I think, 2 out of all the patients we've treated. Yeah. Yes.
Have there been any long-term effect studies?
The long-term.
Long-term effect studies. Doing Botox.
Yeah.
Toxin does wear off after 6 months, but have there been any studies of what it might do to your body if you use it and use it continually, every 6 months?
Yeah, no, that's an important question. Do you finish up by getting muscle weakness and and some of the neuromuscular diseases? That's a very important question, because in fact the answer is it appears not, because long time before it was used for cosmetic use, it was used for correcting squints, but also in very, very large dosages against muscle spasm in stroke patients. And it doesn't appear to have long-term risks for whatever reason. You'd expect it to, but it doesn't. And it's now being used for a whole variety of different, there's about 100 plus medical uses now that the botulinum toxins are used and are approved for. But the other interesting thing, some of the observations are that it may actually be useful for some patients with depression. And the reason for that is that feedback of people that you are in contact with, if they see you as a happier person, you're less frowning, you're less angry, this feedback concept of mood is important. But as regards long-term side effects, not yet. And it's now been used probably, we've been using it now cosmetically for 30 plus years. So it's been used, it was used for probably 45 years for neuromuscular diseases. So it's been a really well-studied drug. Yeah.
Dr. Lowe, what actually is it? Where does it come from?
Sorry, yes, I should have said in an introduction. It was first described by a German physician, Justinus Kerner, in the mid-1800s, when he reported a group of Germans who became paralyzed after eating sausages that were a little older than they should have been. So that was originally the first description of botulinum poisoning. It was then discovered over the years that people who, classical is you eat a can of tomatoes that have been old or opened, the botulinum bacteria will grow, it produces lots of toxins that then paralyze the connection between your nerves and your muscles, and it paralyzes the transmission of chemicals. Of those nerve chemicals that activate your muscles. And that's where the toxin has been extracted from bacteria called Clostridium botulinum, and the toxin is derived from those bacteria. So that's basically it. People with botulism will die, as was described by Kerner, without a worry line on their face and without any sweating. So that was the original description of botulism. Okay.
I read years and years ago that there was an article in the newspaper about human tissue being part of in these injections or something. There was something
Being what?
Human tissue or something. It was a scaremongering article years and years ago in the newspaper when it was kind of just starting to be used.
Well, the drugs, I mean, the Botox and Dysport are so heavily regulated, quite correctly. They're called biologic prescription medicines, and they are one of the most heavily regulated of all approved medicines. So there's no risk of contamination and that sort of thing now. But I mean, there may have been way back. Yeah.
It was a long time ago.
Yeah. Right. So let's carry on. So fillers now, filling and lifting, and that's because we want to transform the aging face from here to here. And basically, the latest fillers can both lift and fill. And they can lift and fill because we're actually replacing volume loss in these areas. So by replacing volume loss here, we will not only recontour the face, but we'll also gradually lift the sagging face. I've shown you this one before. Lips, I'm sorry you can't see that, but subtle fillers for lip enhancement are extremely valuable. There are some patients that really do like slightly fuller lips than they're born with, and I think subtle is the message. And someone mentioned and asked about the actress that had the over-injected lips. she didn't just have over-injected lips, she had a significant allergic reaction to the filler that was injected, and she also had probably some permanent filler injected, and the message, in my opinion, is that permanent fillers should not be used. There are still some around, and there are still some people injecting them. They shouldn't be, in my opinion, because our faces change with age, and therefore it would make sense to not have a permanent filler that will not change. The beauty of these fillers that we now use are that they gradually deteriorate, they gradually disappear. Some of them do induce new collagen in your skin, but these are some of the potential risks of those fillers. And again, fillers can be injected by anybody in this country. In other countries, they are more regulated. And I think, again, that should be addressed. What about lasers? A United States dermatologist, Leon Goldman, could be really thought of as the father of medical lasers. He developed the very first medical laser to actually get rid of tattoos, and coincidentally started treating blue-green tattoos in servicemen, and then found that the hair adjacent to the tattoo was also successfully removed with the lasers. So he developed this whole use of lasers in medicine that are now used in surgery, gynecology, gastroenterology, head and neck surgery, obviously ophthalmology, lots of use there for medical lasers. But as I say, the very first use was in dermatology. And the very first laser actually was a ruby laser that Goldman used to get rid of tattoos, and also found that he could also reduce hair. And we now have many different lasers, and lasers can be developed now for medical use with all of these different wavelengths, and they can target different aspects of body tissue and skin tissue. And so it is a whole developing scientific area. We looked at a whole variety. This was the original ruby laser that was modified to treat the birthmark I showed you before. And what we noticed in some of these patients were that they actually had dark circles, which is a very common problem in Asian, and also other people have this discoloration under the eyes. Well, some of the lasers that were actually very useful for birthmarks can also significantly improve dark circles. We can use some of the pulse lights and lasers to actually rejuvenate the skin by targeting pigment. The reason that lasers target pigment is because they are preferentially absorbed, or some of them are absorbed more by the pigment chromophores, which then are absorbing more laser, which then the laser will basically vaporize and will clear those areas much more. It will selectively damage the brown compared to the rest of the skin. So it's a factor called selective laser thermolysis.
Sorry, can I just ask with the brown spots?
Yeah.
I'm always intrigued of aging spots versus skin damaged brown spots. Is there a difference, or is it the same thing?
There is a difference,
That's what I
and
thought.
age spots are generally the crusted, slightly brown patches that we often get on our bodies, our trunks, and they're called keratoses, and they're raised brown, slightly waxy, sometimes dry and scaly areas. The true sunspots that we get on our faces and hands and upper chest and neck are absolutely related to sun damage, and these are flat, and they can be actually the importance is that they are a sign of sun damage, and they also are a sign that sometimes they can go on they have show the person as having a higher risk of skin cancers as well. So there are differences. Some of the lasers can be targeted to treat red, and so one of the original uses of the lasers in the 1970s and 80s was to develop treatments for the red birthmarks like Gorbachev has on his scalp. But indeed, there's a lot of other dermatology conditions that have, as part of their problems, excessively red skin. And the reasons that some of the lasers work extremely well in these areas is they are absorbed. It's a wavelength that is absorbed more by the red blood cells in the enlarged blood vessels, so they can selectively target those blood vessels. And then, in addition, you can also use the lasers in a very controlled way to rejuvenate sun-damaged skin. And these are some of the newer lasers called fractional lasers. And the reason that fractional lasers work so safely as well as effectively is that they literally send separated micro channels of energy into the skin. This is the outer skin, this is the underskin or the dermis, and these lasers, the fractional lasers, send these micro channels into the skin, and you can actually skip areas and you can get rapid healing around from those little skip areas. So it's really a quite interesting technological developments. What about radio frequency? I've almost finished. Radio frequency can be used very successfully to tighten with the collagen fibrils. They can stimulate collagen bundles, and that can actually tighten and reduce jowls, and you can see this sequential appearances. This is not a replacement for facelifting, it is not a replacement for neck lifting, and the answer is that patient selection is obviously critical, but in the correct sort of patient you can get significant improvement with radio frequency. The other things that we've really learned over the years is to combine these different treatments to get the maximum improvement. And this combination concept where the different treatments are synergistic with each other, where in this particular person we've used fillers on the face and the lips. I've used the Botox on the forehead and the crow's feet area to open the eyes. You can see that there was this sagging of the upper eyelids, and this is now open significantly with Botox. The fractional lasers have been used to rejuvenate the skin, and the combination of thermage also for the upper face. So again, by combining these different treatment options, you can actually get synergistic improvement. And there are many patients that, and I'm not discounting plastic surgery at all, there are some patients that would definitely benefit from plastic surgery. This patient would benefit as an alternative to facelift surgery, and then having the lasers and the Botox as a secondary treatment. So again, combinations with and without surgery are very practical. Some of the latest trends, some of you may have heard about the thread lifts. Thread lifts are actually, the first thread lifts were developed probably 15 years ago, and they've been replaced by more usable thread lifts. I think we're still finding the true place of non-surgical thread lifts, which actually are placed under the skin surface as an alternative to more significant surgery. Platelet-rich injections, which supposedly contain growth factors, which then stimulate new collagen by injecting under the skin. I think again, there's one of the situations here are that there's several different machines that can harvest platelets, and it depends on the type of platelet extraction. And then fat loss and combining treatment. So they can all be combined with a natural look. This, in my opinion, isn't a natural look, but it may be a perfect look for somebody walking around the streets of Hollywood or parts of Manhattan. I don't think it would be, or maybe it would be now in parts of London. But to me, this isn't the ideal result. I think the the answer is it would be nice to retain expression, and it's quite practical to retain expression with the correct use of Botox. So last slide, I think you can get realistic results from definitely sun protection, from some creams, definitely the prescription products, and maybe a few of the non-prescriptions, certainly some of the injectables to be sure that they are the safe injectables, some lasers, lights and devices such as radio frequency, and I think some physicians and surgeons. And the message is there's never any cosmetic emergency, so do your homework carefully. And thank you for your attention. Thank you.